Yes, sir. We are live now.
Prashant, please start.
Good evening. A warm welcome to all the panelists and delegates for today's evening webinar under the banner of EPIC, that is Endo-Physician Interconnect. This is a series of webinars that we are doing on adrenal medicine. This is a session 4. This is the fourth session on Pheochromocytoma, screening, diagnosis, and management. And I'd like to invite Dr. Saptarshi to take the session ahead. Yes.
Thank you, Prashant. A very, very warm welcome to all the delegates who have joined today for this webinar. So, adrenal is one topic which we don't discuss that often. So, we keep on discussing diabetes, we keep on, maybe nowadays we have started discussing thyroid a lot, we keep on discussing bones, but this is a very, very important aspect of endocrine disease, and even there are so many common issues. It's not only about hardcore endocrinology. We in our day-to-day practice, we need to have the basic knowledge about adrenal medicine, and the endeavor of this series of webinars is to make you acquainted with the basics of adrenal medicine. So last time we had a very interesting discussion on primary hyperaldosteronism. This time, our topic is going to be Pheochromocytoma, and we have a very eminent set of faculty to discuss the same. So, Prashant, will you move the slide for Dr. Rakesh's introduction? Yeah. So, we have with us, this program was planned by Dr. Ganpati, Dr. Sanjay Kalra, and Dr. Rakesh Sahai. So, they are the current, past, and the president elect for Endocrine Society of India. So we are honored to have all three of them as our guide. And I have the pleasure of inviting Dr. Rakesh Sahai today as a panelist and a chairperson and a coordinator for this session. So can you move the slide, please, Dr. Prashant? Yeah. So you need to get the slide back to Dr. Rakesh. So Dr. Rakesh Sahai is a very, very eminent national and endocrinologist of national and international repute. He is the president-elect of Endocrine Society of India. He has been the vice president of IRO, executive committee member of National RSSDI. He has been the former secretary of Endocrine Society of India. He is one of the founder secretaries of South Asian Federation of Endocrine Societies, which is also known as SAFIS. So multiple awards are there, including numerous fellowships, numerous from international as well as national societies. He has delivered the highest senior lectureship audition on behalf of Association of Physicians of India in 2008. More than 130 publications, many of them very well cited. And Dr. Rakesh, I would now like to invite you to introduce our panelists and set up the stage for today's discussion on Pheochromocytoma.
Thank you, Dr. Saptarshi, and a warm welcome to all those who have joined the program today. As mentioned earlier, this is an important series of webinars that we are conducting. We had 6 conducted last year, and this is the 4th in this series in this year. So this is an important series looking at the adrenal gland, looking at various presentations of adrenal disorders. And today we have a very interesting presentation. This is going to be on Pheochromocytoma. As we all know, this is a very important problem, which is not so uncommon, and it needs to be sort of understood to. I mean, there are special set of situations where you screen for Pheochromocytoma. How do you screen for it? How do you diagnose that? So all these challenges are going to be presented today. And I would like to, before we begin, I would like to thank Dr. Saptarshi, who has been the backbone behind this whole program, whole series of programs. He has been very actively involved in organizing these programs. So I thank him for all the hard work that is putting in this series of webinars that are being conducted. And today we have with us, can I have the next slide? today to introduce the speaker for today. We have Dr. Ritesh Agarwal. He's a very eminent endocrinologist from from the state of Orissa. He has a immense contribution in the field of endocrinology. Now he's practicing at Bhubaneswar in the AMRI hospital in Bhubaneswar. He has done his DM in endocrinology from Calcutta. He's also recently been awarded the fellowship of the American College of Endocrinology, and he has several publications in national and international journals. He's won several prizes for presentations at various fora like at the state level and the national level. He has also recently won a prize in the ESICON when it was held in Orissa. So I have great pleasure in introducing Dr. Ritesh Agarwal, and he would be speaking on Pheochromocytoma, and then we have a panel discussion. I would also like to introduce the panelists who are there with us today. We have Professor Mohammad Ibrahim Kamse who is from the working at the Iran University of Medical Sciences, and he has a lot of international experience in the field of endocrinology and various other areas. His research interests reflect in his wide range of publications. He has more than 200 publications in various national and international journals. He is currently the head of the Department of Endocrinology and Metabolism since the year 2007 to almost last 15 years, 15 years. He's been heading the Department of Endocrinology at the Iran Institute of Medical Sciences in Tehran. He is also the head of research there at the Iranian University. He is the program manager for for the internal medicine department and the Department of Endocrinology. Also heads the cancer network at the Iran Institute of Medical Sciences. So as we see, he has got a immense experience in the field of endocrinology and the and oncology also. So we have great pleasure in welcoming Professor Ibrahim Kamse to this program today. Along with him, we also have Dr. Shruti Chandrasekharan, who's an equally eminent endocrinologist from the city of Chennai. She's at the Rela Hospital in Chennai, which is founded by the famous transplant surgeon in Chennai. So she is very busy in the field of transplant medicine, transplant endocrinology, as you can see that, and she's also very keenly interested in adrenal disorders and also in transgender medicine. She also has several publications in international and national journals, and she is going to be discussing today about this problem of Pheochromocytoma in the panel discussion. So over to Dr. Ritesh. And we have none other than Dr. Saptarshi, who is also going to be with us in the panel discussion. He's a senior consultant in endocrinologist, and also he heads the Department of Endocrinology at Max Pratapganj in Delhi. He's the director of eHealth, Diabetes and Endocrinology Center at Noida. He's received several awards. He's a member of the American Association of Clinical Endocrinologists, the Endocrine Society of India. He's been very actively involved in the endocrine activities of the Endocrine Society of India, also with the ISBMR and the ISPE. He is authored several articles in national and international journals, and also he has been the past president of the Speed Society. So a warm welcome to Saptarshi also. And we move on to the presentation from Dr. Ritesh, and then we'll have an interesting panel discussion.
So, thank you, sir. And as you told, with your blessing, I got the FSE this year only. And thank you, Dr. Saptarshi and Samarth to invite me in this panels of the adrenal discussion, which is a most important topic in our day-to-day practice also. So pheochromocytoma, which comes as a evaluation of secondary hypertension, and which is the most common topic or the discussion we are seeing in our day-to-day practice. So before going, I will mostly discuss more solely on the pheochromocytoma, except the other secondary cause of hypertension. So I will flow through the introduction, diagnosis, management, and special situation, how the pheochromocytoma will approach. So pheochromocytoma, it is a type of catecholamine secreting tumor that arises from the catecholamine cell or the chromaffin cell of the adrenal medulla. The term coined in 1912, and it can be distinguished from paraganglioma. So the catecholamine producing tumor are mostly arises from the neural crest, that is sympathoadrenal progenitor cell, which leads to neuroblastoma. Chromaffin cell, if it is intraadrenal, that is pheochromocytoma, extraadrenal, that is paraganglioma, or sympathetic ganglionic cell, that is ganglioneuroma. So the catecholamines producing tumors are generally pheochromocytoma, which is intraadrenal, paraganglioma, which is extraadrenal, ganglioneuroma, neuroblastoma, codectoma, and glomus jugulare tumor. And these are the products from these cells. What we are getting are the catecholamine and their metabolites, which helpful in the diagnosis of the pheochromocytoma, which is mostly come out in the excess amount during this tumor secretion. So this is the catecholamine like tyrosine, L-dopa, dopamine, which is converted to norepinephrine, epinephrine. These are the baseline catecholamines, which can be metabolized to the homovenilic acid, normetanephrine, metanephrine, or vinyl mandelic acid by the COMT or the MAO enzyme. And these are the metabolites. We can also measure the metabolite, either the pre-normetanephrine, metanephrine, or VMA, or some cases dopamine or epinephrine and norepinephrine. So come to pheochromocytoma per se, it is a neuroendocrine tumor of the adrenal medulla, originates from the chromaffin cell. 90% are abdominal, and more than 90% are in adrenal medulla. Secretes excessive amount of adrenaline and noradrenaline, and 80% of these tumors are unilateral. We all know from the beginning of our MBBS career, where we mug up the pheochromocytoma as rule of 10, like 10% extra adrenal, 10% occur in children, 10% familial, where the genetic evaluation is much more important, 10% is bilateral or multiple, 10% is recurrent, and 10% are malignant. And if you say pheochromocytoma, only 0.01 to 0.1% of the patients of hypertensive population have pheochromocytoma. Male is to female ratio is equal, mostly found in the 3rd to 10th decade of life, and rare, investigate only if there is a clinical suspicions like severe hypertension or hypertensive crisis, refractory hypertension where more than 4 drugs required to control, hypertension at age below 20 and after 50, and if there is an incidentaloma. So the most common sign and symptom of this pheochromocytoma is the hypertension, headache, perspiration, palpitation, pallor, and the paroxysm of the hypertension and crisis. And the classical triad of this pheochromocytoma are the headache, perspiration, and palpitation. The most important thing here also, this is the most important slide which will guide us to the evaluation of the tumor secretion. If there is a large pheochromocytoma is there, and we are mostly getting the metabolites. I have shown you in the initial slide where the baseline catecholamines, that is the dopamine, epinephrine, norepinephrine, and their metabolites, that is the normetanephrine, metanephrine, which leads to VMA. So
Dr.
if there is a large
sorry to interrupt you. Could you please make the slide full screen, please?
Okay.
Yeah.
So this is the slide which is more guide us to the how we evaluate the case. And if we are dealing with a large pheochromocytoma, we are mostly getting more metabolites of the secretion. If we are small pheo, more catecholamines are there in the secretion. Sporadic pheo, norepinephrine is more secreted than epinephrine. In familial pheo, epinephrine is predominant secretion. In paraganglioma, norepinephrine is there. Codectoma, glomus jugulare, norepinephrine. Ganglioneuroma, malignant pheo, dopamine or HVA. Neuroblastoma, again dopamine. So when you suspect this pheochromocytoma, if there is a hyperadrenergic spells, resistant hypertension, there is a presence of familial syndrome like MEN2, neurofibroma, or VHL, family history of Pheochromocytoma, incidentally discovered adrenal mass, hypertension, pressure response during anesthesia, surgery or angiography, onset of hypertension before 20 years of age, idiopathic dilated cardiomyopathy, or if presence of coronary triad, we can need to evaluate for the secondary hypertension. In the same way, where we need more genetic testing in this Pheochromocytoma, where the age is less than 46 years, multiple tumor, extra-adrenal location, or presence of head and neck paraganglioma, family history, or malignant tumor is there, at least one predictor, any with head and neck paraganglioma, we can go for the gene evaluation. No head and neck paraganglioma with single tumor in extra-adrenal location, also you need to evaluate this gene. All others, that is no head and neck paraganglioma, multiple tumor, or adrenal location, these are the gene we need to evaluate. If there is no predictor, no genetic testing is required. So once you suspect Pheochromocytoma or you get an incidentaloma, to diagnose Pheochromocytoma, we have biochemical diagnosis, and after that it needs to be localized. So for biochemical diagnosis, we need to measure the metabolites, which is better intratumoral metabolism, like the norepinephrine, metanephrine, and the BMA. Plasma-free metanephrine for screening test. Absolute value is much more important than the relative value. In renal failure patient, if the level is more than threefold, it is more promoting to the diagnosis of Pheochromocytoma, and precaution for taking blood sample. So these are the precautions while taking blood sample in the diagnosis of Pheochromocytoma, and it is much more important to evaluate a patient. Stop all interfering talk, I will say. Patients lying supine for at least 20 minutes before sampling. Sample through previously inserted IV line is better. Avoid alcohol and nicotine for 12 hours, preferably after an overnight fast. Important for diabetic diagnostic cutoff, like metanephrine less than 0.3 and normetanephrine less than 0.66 nanomole per liter. And these are the sensitivity and specificity of the different biochemical tests we do for diagnosis of Pheochromocytoma, like the 24-hour urinary catecholamines, 24-hour total metanephrine, catecholamines pulse metanephrine, which has a specificity of around 98%, urinary VMA, and now the plasma metanephrine, which has a sensitivity of 99% with a specificity of 89%. But in 24-hour urinary catecholamines or metanephrines, the false positivity are there. So you have to be careful. And these are the drugs which is responsible for the false positivity, like the TCA, levodopa, methyldopa, labetalol, propranolol, clonidine, ethanol, and some of the cold medications are to be avoided. Hold the medication for at least 2 weeks. And major physical stress also responsible for the false positivity, like hypoglycemia, stroke, or raised intracranial pressure. So we have to be look up these issues while doing the evaluation for urinary test. In case of plasma catecholamines, again, plasma catecholamines more than 2000 picogram per ml is positive. It has a sensitivity of 85% with a specificity of 80%. False positivity same as the 24-hour urinary catecholamine. Also, it has shown false positivity if the patient is on diuretics and smoker. And if there is a suspicion, we can go for the suppression or stimulation test also, like clonidine suppression and glucagon stimulation. So the major criteria for the clonidine suppression, what it did, it usually suppressed the catecholamine secretion, but in Pheochromocytoma it won't. So if after clonidine given 0.3 milligram to a patient, and after 3 hours, if the plasma metanephrine is less than 500 or decrease more than 50%, then there is no Pheochromocytoma. In Pheo, there is no decrease found. And glucagon stimulation, it precipitates the hypertensive crisis. So Pheo patient, but not normal, will have a more than 3% increase in plasma norepinephrine with the glucagon. So this is the suppression test, and this is the stimulation test we can do. After the diagnosis, biochemically, we have to localize the Pheochromocytoma. where more than 90% are adrenal. Extra-adrenal sites are also possible, like the organ of Zucker candle, bladder, myocardium, mediastinum, carotid, and glomus jugular body. CT abdomen, where adrenal Pheo sensitivity is around 93 to 100%. Extra-adrenal sensitivity is around 90%. MRI sensitivity more than CT for the extra-adrenal Pheo, and iodine 123 MIBG scan has been helpful for the multiple tumor or mostly to localize the metastatic one. And this MIBG scan, that is the iodine 123 and 131, but 123 is better, leveled with the meta-iodobenzyl guanidine, and saved for cases where Pheo diagnosed biochemically but no tumor on CT or MRI. After injection of the MIBG, scan can be taken 24, 48, and 72 hours. But with the use of this MIBG, we need to protect our thyroid. So a local solution of 2-drop TID for 9 days, 2 days prior to the start of the MIBG scan, and 7 days after MIBG injection to protect the thyroid gland. There are also false negative scan we will get if the patient is on labetalol, TCA, or phenothiazines group of medication. So we have to withhold this group of medication for at least 4 to 6 weeks prior to the scan. So this is the diffuse metastatic pheochromocytoma demonstrated in the MIBG scan in a 41-year patients. And the other newer investigation to localize are the indium 111 pentriotide scan or the PET scan using the 18 FDG or the fluorodopamine. So this is the diagnostic algorithm how to follow a case of pheochromocytoma, discontinue the interfering medication. Clinical suspicion is very high. Go for the 24-hour urinary fractionated metanephrine, fractionated catecholamine, or plasma fractionated metanephrine, which has a very high sensitivity. Normal, recheck during a spell. If there is more than 2-fold increase above the upper limit of the urinary catecholamine or urine metanephrine, then go for the localization. If the suspicious is low, 24-hour urinary fractionated metanephrine normal, do not need evaluation. Otherwise, go for the test and localize by abdominal MRI or CT scan. Typically, adrenal or paraiotic mass, if it is there, go for the MIBG if the tumor is more than 10 centimeter in size or there is paraganglioma. Negative abdominal imaging, go for the MIBG scan or the indium 111 pentriotide scan or the whole body MRI or PET scan, and plan for the treatment of the pheochromocytoma once you have localized it. So how to proceed for the management? Now the currently mortality because of pheochromocytoma is 0 to 2.7%. Earlier it is around 10 to 15%. Preoperative preparation with the alpha blockade and beta blocker. Anesthetic technique should be monitored and it should be handled with care with the experienced and coordinated team. Preoperative preparation with the combined blockage of the alpha blocker at least 10 to 14 days, followed by the beta blocker, where the phenoxybenzamine is a non-selective alpha and beta blocker. Selective alpha blocker is the prazosin, doxazosin, and terazosin. Metirocin are the different group of synthesis inhibitor. Calcium channel blocker are there. So as I have told, alpha blocker at least start 10 to 14 day pre-op, allow sufficient time to maintain the extracellular fluid to re-expansion to prevent the post-op hypotension. So phenoxybenzamine started at 10 milligram per day, maximum dose of 100 milligram per day can be used. The benefit of selective alpha-1 blocker, there is less risk of orthostasis or reflex tachycardia than phenoxybenzamine, and it can be used for long term if there is a inoperable condition or malignant pheochromocytoma we are facing. Beta blockade, once the alpha blockade is complete, then to prevent the reflex tachycardia or prophylaxis against arrhythmia during surgery, beta blockade is added. Start only after effective alpha blockade. If suspect congestive heart failure or DCM, start with the low dose, and propranolol most studied in Pheo preparation. Start 10 milligram BID. Increase to control, at least maintain a heart rate of 60 to 80 per minute. If BP still not controlled, despite alpha and beta blockade, add calcium channel blocker, AC inhibitor, avoid diuretics as it already extracellular fluid is contracted. During surgery, if there is crisis, we can use IV pentolamine at a dose of 1 milligram IV followed by 5 milligram bolus by infusion. Nitropuracin not more than 3 microgram per kg per minute on nicardipine at a rate of 5 milligram per hour. Preferred induction for anesthesia is the propofol or the etomidate, and laparoscopy for less than 8 centimeter tumor can be taken up. Post-op, most cases can stop all BP medicine post-op. If there is post-op hypotension, it can be taken care by the IV crystalloid. Mostly patients are hypertension free in 74% at 5 year and 45% at 10 year. 24-hour urine collection 2 week post-op to see the biochemical parameter, and then yearly for at least 10 years is required the evaluation during the follow-up. If after operation also the patient has persistent hypertension, these are the some of the conditions we have to think of, like accidental ligation of the polar renal artery, hemodynamic changes, structural changes of the blood vessel or the permanent chronic changes, altered sensitivity of the vessel to the pressure substance, functional or structural renal changes, and coincident of primary hypertension is there. If the tumor is unresectable or malignant, continue antihypertensive in the different way. High dose MIBG octreotide depending on the MIBG scan or octreotide scan pickup, or we can use carboplatin or 5-fluorouracil as a chemotherapeutic medication. In special population pregnancy is there where diagnosis is same as in the non-pregnant cases. No stimulation test MIBG is indicated. MRI and ultrasound are the indication or the diagnostic of choice without contrast. If the tumor is diagnosed before or in the early pregnancy, operation should be safe in the second trimester, or if it is diagnosed later, it is better to do the surgery post-delivery. So thank you for your kind and patient hearing, and I think the topic is open for discussion to all.
Thank you, Dr. Ritesh, for the excellent presentation. We'll now move on to the panel discussion. I would like to invite Dr. Saptarshi, Dr. Shruti, and Dr. Ibrahim to join in the discussion. Over to Dr. Saptarshi.
Thank you, Dr. Ritesh, for the excellent presentation. So I think you have heard most of the aspects of related to Pheochromocytoma. So some of the questions might be overlapping with and is already covered in your presentation. So we'll still have a discussion. So I think Dr. Rakesh, if you could ask the first question.
Yeah. So I think we had a very interesting presentation by Dr. Ritesh, but like to get the view of the panelists, because we want to learn from their rich experience. So I would like to ask Dr. Ibrahim, when would he suspect Pheochromocytoma in a patient? What are all the situations where we would suspect Pheochromocytoma and evaluate for a Pheochromocytoma?
Hello, everybody, and thank you for the invitation. It was a very interesting presentation, and Dr. Ritesh actually covered most of the things that me actually wants to describe. But about the clinical presentation, if you hear me?
Yeah, we can hear you, sir.
Okay.
We can hear you.
About the clinical presentation, as all of you know, that it is extremely variable and depends on some factors, namely the location and the tumor size actually. And secondly, the type, amount, and pattern of hormone secretion. As mentioned, not all pheo and paragangliomas secrete the same amount and type of hormones, and the pattern of secretion is variable. And it also depends on the hereditary or sporadic nature of the tumor and the malignant potential of the tumor. And as mentioned by Dr. Ritesh, if the paraganglioma arises from sympathetic paraganglia, the clinical presentation might be different from those arise from parasympathetic paraganglia. Those arise from sympathetic paraganglia might present with the classic triad of palpitation, headache, diaphoresis, or tremor, dyspnea, and facial pallor. However, we should have in mind that the predominant symptom remains severe and variable hypertension. Most of the patients present with severe resistant hypertension, and it is not. It might be persistent and even not variable. And this hypertension might lead to tissue damage. So if a patient present with dilated cardiomyopathy or unexplained heart failure with hypertension, or hypertrophic cardiomyopathy, or a myocardial infarction in a patient who had no traditional risk factors, we should have in mind the possibility of Pheochromocytoma. As mentioned, the clinical suspicious is very important. Other patients might be present with hemodynamic instability and unexplained orthostatic hypotension. And even patient might present with unexplained weight loss due to increased basal metabolism rate and altered glucose homeostasis. As mentioned, if a patient is a setting of secondary type 2 diabetes, in particular with associated with persistent and severe hypertension, we should have high suspicion for Pheochromocytoma. The symptoms might be spontaneous, or it might be induced by a stimuli. So if a patient gives a history of symptoms, hypertensive symptoms or other symptoms after special foods, especially those rich in tyranny, we should be suspected of this disease. Or if after physical activity or a minor trauma into the abdomen, or after general anesthesia, or after getting some medications that's mentioned by Ritesh. So we should be suspected if these symptoms presented by the patients. Otherwise, patients who had paraganglioma arise from parasympathetic paraganglia. They might be silent, hormonally silent, no hormonal secretion, but they might present with mass lesion in the base of the skull or in the neck. So a mass, an unexplained mass in head and neck, in base of the skull or in the neck, that is unexplained should be suspected as Pheochromocytoma as well. So in brief, the high clinical suspicious is necessary, and 4 groups of patients should be screened. Those with treatment-resistant hypertension, patients who present with unexplained spells, those with adrenal incidentalomas, and patients who have a history, personal history or family history of genetic syndromes associated with Pheochromocytoma. So for these patients and in these settings with clinical suspicious of catecholamine excess, we should screen the patient. Thank you.
Yeah, thank you, Dr. Ibrahim. I think that was brilliant. I mean, you spoke of the entire spectrum of presentations, right from right from the classic ones to the very odd, very rare presentations, and the real, the various situations where we should suspect. I think that was very nice. And Dr. Saptarshi, would you like?
Yeah. So Dr. Shruti, there are a very warm welcome. So we have talked about the presentation mostly in adult patients. And we know there is a distinct population of patients who have a genetic etiology behind the Pheochromocytoma, and many of them present at an younger age. So when should you suspect that that the patient might be having a genetic etiology and you need to get a genetic test done?
Thank you, Dr. Saptareshi. That was a great question. As you actually answered, so there are a couple of conditions where we can suspect a genetic cause. One is a younger age, as you had pointed out. If there is a family history that the patient is coming and telling you that my uncle had, a syndrome called MEN2 or VHL, if they come up with a family history, that would also give us a clue that this patient could have a genetic cause. The other things that would make us consider genetic is if somebody has a bilateral pheochromocytoma. If somebody presents with bilateral pheo or a paraganglioma. Paraganglioma are known to have a familial condition or a genetic cause. So even though we know that majority of these tumors are sporadic, about 30 to 40% of these are genetically inherited tumors. So we need to be aware of that. So as I told you, younger age, family history, bilateral bilateral pheochromocytoma, paraganglioma, and also if you have a metastatic disease. A lot of paraganglioma, especially with SDHP mutation, can present with metastasis years after as well, after the presentation. So we need to be aware of that. So these are the points which would make me think that this could be a genetic cause of pheo. Thank you.
Thank you, Dr. Shruti.
Thank you, Dr. Shruti. So to Ritesh, we would like to ask him, how about the manifestation of children? You spoke about the entire spectrum of pheo, but could you tell us something more about pheochromocytomas occurring in children?
Yes, sir. In my presentation, I told about the role of 10 in pheochromocytoma, but recently an article published in IJEM where the childhood pheochromocytoma is well studied in the different part, well taken, where they found that the childhood pheochromocytoma can range from 10% to 90%. That means 10% of the children are having pheochromocytoma, 20% are bilateral, 30% are extra-adrenal, 40% are having more risk, and mostly asymptomatic pheochromocytoma are found in the adult population. But most of the 80% of the children with pheochromocytoma are symptomatic, and they are mostly associated with the familial or genetic cause in their syndromic association. So in that way, children are more presentable.
Yeah, so I think we are more and more realizing that the rule of 10, which was very classically described, is probably not holding true every time. And we are seeing more and more of the extra-adrenal manifestations, and particularly when you're looking at syndromic manifestations. And you've very clearly told us how in children you have these, you don't look at the rule of 10, but you're looking at different manifestations. Thank you, Dr. Ritesh.
So thank you, Dr. Ritesh. Thank you, Dr. Sahay. So Professor Ibrahim, so if I might ask you, so Dr. Ritesh has elaborated already on the basic precautions before collecting samples for metanephrine or catecholamine. So what is your institutional practice and what precautions do you follow for collection of the samples for diagnosis of pheochromocytoma, biochemical confirmation?
Yes. The routine test for measurement of catecholamine metabolites in urine is currently HPLC, high performance liquid chromatography, because it is more available. Other measures, such as tandem mass spectrometry, is more valid, but the issue is that it is not available for most of the routine clinical labs. So the precautions that mentioned by Dr. Ritesh, and I reemphasize now, is for mainly for the HPLC method. The other thing is that these interference is more for urine metabolites, and it is less for plasma sample metabolite measurements. So the first question is that, is there any dietary restriction required prior to collecting samples? It is not generally recommended for the majority of patients. However, some experts recommend a 3-day diet free from caffeine, almonds, nuts, cheese, and chocolate prior to sample collections. He nicely mentioned about the role of fasting and rest prior to testing, because the stress might produce false positive results. The time for the fasting is controversial, but it seems that fasting for at least 4 hours is sufficient, and the patient should have a supine rest 30 minutes before collecting the plasma samples. The most important thing is to stop some medicines in order to reduce the false positive results. And the list of these medicines are very long, but the important medicines that currently might routinely used by the patients include paracetamol, acetaminophen, theophylline alpha blockers, dexamethasones, beta blockers, vasodilators, tricyclic antidepressant, monoamine oxidase inhibitors, AC inhibitors, calcium channel blockers, and diuretics, and of course, lithium. The medicines that produce false negative results, the list is short. It only includes alpha-2 receptor agonist and dopamine agonist. In some patients, physicians might decide to assay chromogranin A. It is highly sensitive compared to catecholamine metabolites, but it is less specific. So if the level of the catecholamine metabolites are equivocal, but the clinical suspicious is still high, we could measure chromogranin A because of its high sensitivity for sporadic pheochromocytoma. The other things that I could add it to my previous precautions is that it is better to have 2 24-hour urine collection instead of 1, and it does not need to be on 2 consecutive days. But when you have 2 urinary collection, it might have a better result for good decision making. And the other thing is that there is no age and gender influence, at least in adults, on catecholamine metabolites. But in children, of course, there is age and gender difference for the catecholamine metabolites measurements. For now, I think I have no further comments on that. If there is any other question, I will answer. Thank you.
Thank you,
Dr. Ibrahim. Yeah, I think you have actually given us a good illustration of what are all the interferences and how we should go about with the testing. So let's move to Dr. Shruti, and can you actually clarify on what are the pros and cons of various tests and how to choose which test to do? Because there's so many of them available. So which one would you think would be? How do you decide between which test to go for?
So before I answer that question, I have a disclaimer. There will be institution-related protocols and country-related protocols that will be followed. So what I was taught in my training is probably not what I follow in India. So I think if you have a protocol that is validated and you have practiced and it works for your practice, I would say stick to that. I think that's what universally the papers say. So that is the first disclaimer I want to start off saying for this answer. Regarding the pros and cons, I do 2 things before I do urinary catecholamines or a plasma levels. I calculate the pre-test probability. How high are the chances that this patient could have right? That's one question I ask myself, putting into all history that I collect from the patient. If I'm screening it for, say, a resistant hypertension or something that looks like spell, but not clearly spell, I go for a urinary. That's what I do. So as I told you, you please stick to what you do. I consider doing a 24-hour urine catecholamines and metanephrines, probably because this is a very, very good sensitive and a very excellent specific test. So it will tell me whether this patient has, and my index to start for screening this patient is low to moderate anyway. So I can get this with a very good sensitive and a specific test. So I would opt for a 24-hour urine test, urine catecholamines or the metanephrines. But if I have a patient who has a very high suspicion, characteristic spells or whatever we went through in the presentation with Dr. Ritesh, if a patient has all these high suspicion for a catecholamine secreting tumor, I would prefer a plasma, right? That's what I do. The reason why I do this is the plasma has excellent sensitivity, but the specificity is not very good. So the specificity is about 70 to 80%. Elderly patients, the specificity comes down. So which means we'll pick up a lot of false positive reports when we do a plasma. So we will have to screen them more and go for unnecessary imaging. So this is what I do. So if I have an eye index of suspicion, I go for a plasma test, and moderate to low, then I do a urine. I agree some places do both plasma and urine. So that depends on the cost involved with the treatment. We all know the expense, the cost associated with these testing modalities. So if you have somebody who can spend, you can probably get both of these into practice. But the precaution in terms of plasma, having an indwelling catheter left for 30 minutes and having a specific cutoff for supine and lying down. So the cutoff for plasma metanephrines and normetanephrines would differ on how we collect the sample. So it is very important we supervise the collection. So it's important not to just go for one particular test. The point is how effectively can we actually use it into practice. So there is not, both plasma and urine can be used. And Dr. Ritesh has told in patients with end-stage renal disease or chronic kidney disease, where we cannot use a urine sample, or in children. We talked about paragangliomas and Pheo in children, where collecting a 24-hour urine sample could be a challenge for parents. We could definitely opt for a plasma sample, taking into account the modality or mode in which we do the plasma sample. Again, in renal failure patients, we could take 3 times the upper limit of normal for norepinephrine and epinephrine. So we have to understand whatever test we do, if you have a robustly secreting catecholamine secreting tumor, the results will be grossly abnormal. It will be 3 to 4 times the upper limit of normal. So that's what the studies have shown. So we need to also interpret these mildly elevated tests carefully and not to investigate them any further. No, that depends on the clinical judgment and the patient sitting in front of us. So I would stop here, sir.
Thank you, Dr. Shruti. So I would also ask a small question to both Dr. Ibrahim and Shruti. So we get many of these patients who are like admitted in ICU. You get a call that is imaging was done, and the patient is also hypertensive, and there is a adrenal mass. And so, is that the right time to get a patient admitted in ICU? Is that the right time to get a metanephrine or catecholamine done?
I will let Dr. Ibrahim take the question first, or should I go first?
Professor Ibrahim, your comments on that. So if patient is admitted in ICU, it's on, say, having a sick patient, maybe having sepsis. So would you consider first stabilize the patient, get this test done? So again, very common situation in clinical practice. Yeah.
It's a very good question, because in the setting of the intensive care unit, the catecholamine levels, as all of us know, is very high. I'm not sure really about the cut points of the catecholamine levels in the ICU settings, but more than 2 or 4 folds upper limit of normal might not be sufficient in that setting. If the patient has a very high level of the catecholamine metabolites, it would be helpful, but the moderately high levels might not be helpful for diagnosis. I think it is better to stabilize the patient if we could, or if the facility, if we have the facility, we go for the anatomic localization or functional localization without having biochemical confirmation if we could not manage the blood pressure, especially with the medications in a good level.
Dr. Shruti, you want to add something more?
That's probably right, but just few years before the pandemic, a year before the pandemic, we had a patient who presented with Pheo crisis. He had a hypotension, didn't present with hypotension and shock. He came in with severe crisis. Of course, the Pheo was found out by an imaging modality. So obviously we didn't think of Pheo. We thought it was sepsis and stuff. In that case, with the characteristic necrosis and the other features that was present in the CT images and looking at the CT Hounsfield units, I agree with you. Probably we should have stabilized him and then investigated. But given the scenario, to stabilize him and to know what it was, we did go ahead and do the urinary catecholamine level. And this patient turned out to have a dopamine secreting Pheo. So his 24-hour urine dopamine was very high. I didn't talk about that in the pros and cons of the testing, the question before. But so I would say that investigating in the ICU setting, I think we should use our clinical judgment. If you think the patient, if you again have a low index or low threshold for Pheo, then you can stabilize the patient and do it once the patient is fine. But if you think imaging that was done, ideally in endocrinology, we always do a biochemical test followed by imaging. But a lot of times in Pheo and paraganglioma, it's usually patient get the imaging and they and then get referred to us for hormone evaluation. So if that is a scenario, you could consider doing it even in the ICU setting, is my opinion. I'm sure you could have different answers for this question.
So thank you both, Dr. Shruti and Professor Ibrahim. So now my question to Dr. Ritesh. So we are discussing sick patients, but again, very commonly it's a very common situation that we get an abdominal imaging and we see there is a 2 centimeter or 3 centimeter unilateral adrenal mass. So which we often label as adrenal incidental mass. So how do you approach such a case, and do all adrenal lesions require tests to rule out pheochromocytoma?
Yeah, so definitely it is the most common way we are seeing in patient in our day-to-day practice. So before going to this question, in the same previous question, ICU setting, it is better to see how the patient admitted to the ICU. It is the hypertensive crisis which is responsible for the admission to the ICU, or for the any other reason. Again, we found the hypertension is the known to the patient, and again it is the adrenal incidental which gives us a call to attend the patient. So it is not all the adrenal, though it is a practical guideline to evaluate all the adrenal mass in the form of pheochromocytoma before surgery, but there is no proper guideline to issue it. But in CT scan finding, some of the articles are saying that if in the CT scan finding the Hounsfield unit is less than 10, it is more commonly mostly the lipid store where the pheochromocytoma is very little chance, and you do not need to follow the cumbersome test to find out the pheochromocytoma. Second thing, it is has also been in the different publications and guidelines that if the tumor size is less than 3, hypodense, clear margin, then you need to follow up the cases after 3 months and yearly to see the growing of the tumor. If it is not growing, you just need to make the patient follow up. If the patient has a size of more than 4 centimeter, if on the CT scan you are getting a heterogeneous mass, then you are mostly facing a case of pheochromocytoma where biochemical testing is required. So I think if at the conclusion, if the CT scan finding of HU field is less than 10, there is no need to proceed as the guideline says, or if the tumor size is less than 3 centimeter homogeneous with clear-cut margin, we can follow up the patient without evaluating further. Unless and until the patient has a suspicious of pheochromocytoma in the different clinical parameter I have said.
Thank you, Dr. Ritesh. Dr. Shruti, you wanted to add something?
No, that's perfect. I think we probably do the same thing. That's bang on. That answer is fine. The only thing is there is only 3% incidence of Pheo in the incidentaloma. So if we follow what Ritesh said, we can probably avoid unnecessary investigation. So look at the CT, discuss it with the radiologist. I think discussing with the radiologist is the most important thing before we decide anything for an incidentaloma. So this is a teamwork. It's just not us taking a call.
Thank you, Dr. Shruti. From the biochemical diagnosis, now we'll move on to the localization, and very often we use MIBG scans for localization. So I would like to ask Professor Abraham as to what are the precautions that we should take before going for this MIBG scan, and what are the caveats that could be there when you're using MIBG for localization.
MIBG and other functional imagings are superior to anatomical imagings regarding specificity. And they used to confirm the avidity of the primary lesion or to assess the extra-adrenal sources of catecholamine excess. The most important thing I think is to protect the thyroid from the radioactivity. So as mentioned in the presentation, giving a potassium iodide tablet or Lugol solution to the patients prior to MIBG is very important to protect the thyroid. But other things that is common with the biochemical tests, for example, avoiding specific drugs such as tricyclic antidepressants, antihypertensives, or the congestants containing pseudoephedrine or phenylephrine is also a major precaution before doing MIBG. But one thing remains that is about the sensitivity of the MIBG and its specificity for paragangliomas other than sporadic Pheochromocytoma. The specificity and sensitivity is lower for paraganglioma, especially in head and neck, and those paragangliomas with succinate positive mutation. So in these settings, for head and neck paraganglioma and those who have succinated dehydrogenase mutation, it is better to do gallium-68 dotatate PET or FDG PET to detect, to localize the tumor in the neck or other parts of the body except for the adrenal glands. The most important thing, as I mentioned, is to protect thyroid gland and to use other imaging techniques, other imaging modalities for paragangliomas outside the adrenal gland. Thank you.
Dr. Rakesh, can I add one thing, Dr. Saptareshi, if you don't mind?
Sure. Please.
So that was an excellent answer, Dr. Abraham. So I just wanted to add something. If you have a clear-cut lesion in the CT or an MR, MIBG is not indicated for all the patients. If you're thinking of a metastatic disease or a tumor that is very large in size, say more than 8 to 10 centimeter, then an MIBG can be considered. Or now we have even DOTA PET and the other imaging modalities which can be considered. So MIBG is not required, is not a mandatory test for all patients with Pheochromocytoma or a paraganglioma. And the other thing that I want to say is MIBG alone cannot be used for planning surgery because even the normal adrenal gland will concentrate MIBG. I mean, the dye will be concentrated by normal adrenal gland as well. So we have, when we were in training, we have burnt our fingers by doing this. And then we had a normal adrenal gland which was taking up the dye. So you should always have a CT or an MR. You can prefer either CT or an MR. That depends on your practice. Only that has to be localized. Of course, these scans are helpful for an extra abdominal or a thoracic or a head and neck pheo or a paraganglioma. It's useful for that and for probably for a metastatic disease, but not mandatory for all patients, and never decide the surgical modality or method looking at the MIBG scan.
You are true, but may I add a point?
Yeah, absolutely. Please.
You are totally right. But in patients who have, for those patients that we do not have very high clinical suspicious for Pheochromocytoma, and the biochemical tests are not exclusive, But still, we do have some suspicions about Phil. Doing MIBG might help because it is more specific. I agree with you that we do not go for MIBG for all of the patients, but extra for metastatic, actually we do that. And for those patients who have equivocal biochemical results and who do not have very high clinical suspicions, it might be helpful to localize the tumor and show that they concentrate the radioactive iodine.
So thank you, Dr. Shruti and Professor Ibrahim. So we discussed about the clinical features, then the biochemical parameters, biochemical tests, then imaging. Now, once we have the diagnosis, the next step is how to control the blood pressure before surgery. So that is a very challenging task. So Dr. Shruti, so I will take the opinion of rest of the panelists as well later. So your institutional practice of preoperative BP management for pheochromocytoma.
So what we use is we start with prazosin. That's the treatment, that's the drug that I use. I was trained using doxazosine as a fellowship. Very little phenoxybenzamine, probably only in pregnancy, but I've never had a pregnant pheo in the last few years at all. So I've never used phenoxybenzamine. So I start with very low dose of prazosin, maybe 1 to 2 milligram. I ask the patient to monitor the blood pressure twice a day at least, take an average of the blood pressure, like how we do a home blood pressure monitoring. I ask them to send that to me by email or other modalities. And I make sure that the patient don't develop orthostatic hypotension, because it's really, really annoying to have an orthostatic hypotension in this condition. So slowly up titrate the prazosin. That's what I use. To maintain a systolic blood pressure of 120, that's what I aim, and a diastolic blood pressure of 60 to 80. At the same time, not having orthostasis. So maybe, as Dr. Ritesh said, maybe the second or the third day after starting the alpha blocker, I ask them to salt load themselves, because this is to prevent an intravascular volume contraction, which can happen with the catecholamine secreting tumors. So I ask them to salt load, or if the patient is going to be admitted in the hospital pre-surgery, very important to give them a saline loading, normal saline loading. So that's very important second step, even before we think of a beta blocker. So alpha blocker, monitoring blood pressure, titrating the alpha blocker slowly, preventing orthostasis, adding a salt tablet or IV saline, depending on your patient condition. And then depending on the heart rate, or if the patient develops tachycardia because of the alpha blocker and the other reasons, then I start beta blocker. Only then I start beta blocker, and I titrate it depending on the underlying cardiac problems, etc. And I use propranolol. I don't use a combined alpha beta. Propranolol is what I'm very comfortable with. It works very well, and is slowly up titrated to even 120 milligrams if required of propranolol. Some patients who have airway disease where I can't use propranolol, then I use a metoprolol, a low dose metoprolol, and up titrate it. And if the blood pressure is still not in target and I'm not able to get the patient, then I add calcium channel blocker, amlodipine, nifedipine. You can, CCBs are actually, again, wonderful drugs in getting the blood pressure to target after the alpha blockers, salt loading, preventing orthostasis, beta blockers, and calcium channel blockers. So these are the drugs. But if you look through the literature, meterosin can also be used for blood pressure control, but I don't use that. So it's usually an alpha blocker, beta blocker, plus or minus a calcium channel blocker with good salt loading, blood pressure monitoring, and preventing of orthostasis. And this should at least be done for a week, preferably even 2 weeks. If the surgery can wait, get the patient ready for the surgery, have an excellent team, because intraoperatively, I'm not going to be doing anything. It all depends on the anesthesia and the surgeon who's taking care of the patient. So the final outcome depends on the team that we have. If you have an excellent anesthesia team, like what Dr. Ritesh said, in terms of nitroprazide and other medications that they can use, the outcome will be really good.
Thank you, Dr. Shruti. So there is one common question which is being asked and which is often gets discussed in many of the forums, is whether a sustained release form of prazosin is better or a short acting prazosin is better. So your opinion on that?
I don't use sustained release. I use short acting. I mean, it's just probably easy for me to up titrate it. I usually use it twice a day. even though getting it is a big of a challenge. That's my opinion. I'm sure that to differ from one person to the other. I mean, I don't know what the others have to say about that, but I use a non-sustained preparation of prazosin.
So, Professor Ibrahim, I think this is the most important part of today's program. How do you prepare these patients for surgery?
I think Dr. Shruti discussed in depth about this question. I do the same. And the most important thing is to stabilize blood pressure and to bring the intravascular volume to its original volume. Because as all of us know, these patients have intravascular volume depletion. And it is important to control the blood pressure and make the intravascular volume sufficient with alpha blockers, prazosin actually, short acting, I agree, and then adding beta blockers and if necessary, other antihypertensive medications. That is the way.
So thank you, Professor Ibrahim. So Dr. Rakesh, Dr. Ritesh, you want to add anything to that?
No, sir. In our institution also, we are following the same. I will, specially, I will do the alpha blocker at least for 7 days. Then we'll check, as we see in the nasal stiffness there, or in that way, we will increase the dose to the maximum dose what we are giving. And I will prefer prazosin, not the phenoxybenzamin, followed by the beta blocker propranolol.
So thank you, Dr. Rakesh. You have anything to add on
No,
that?
I think we had a very good. Points were made by Dr. Shruti and Dr. Ibrahim. So I think we.
So I think this is something we want to highlight to everybody. So this is one blood pressure, one hypertensive situation where you actually have to give extra salt. So I had a fight with a young anesthetist that why are you recommending extra salt? So I had to reinforce that this is the most probably one of the unique situations where for hypertension you need to give extra salt. So that is one important thing. I think Dr. Shruti, another important thing is that if you're giving a sustained release prazosin whenever, so that will be more long acting. So whenever you take out the tumor, so there is a drop in blood pressure. So the chance of intraoperative hypotension after removal of the tumor, that is actually slightly higher with the sustained release form of prazosin. So I think that is why it's better to use the shorter acting form. I totally agree with you. In AIMS also, we used to follow the same practice, no difference in that. Prazosin followed by beta blocker, not getting controlled, we add a calcium channel blocker, and then salt loading, if possible, 1-2 days prior to admission, saline infusion. So that is everything. In AIMS, we used to follow the same thing. Even in current practice, also I do the same. So, last question for Dr. Ritesh, Professor Sai, if you would like to ask.
Yeah. Ritesh, you also spoke about pheochromocytomas being diagnosed in pregnancy. You briefly mentioned about that. Can you just give us a little more details on that? You're muted, Ritesh. I think you're muted.
Yeah. So pheochromocytoma during pregnancy, I also touched a little in my presentation also. So for the diagnosis during pregnancy or non-pregnant cases, it is the same. But here we will only use the ultrasound and MRI without contrast. There is no use of CT scan or the MIBG scan for during pregnancy. Mostly, if the pregnancy pheochromocytoma is diagnosed before 20 weeks, then it is better to diagnose and surgery at second trimester. If it is diagnosed late, it is better to control the blood pressure and follow till at least post-delivery to reach to the pheochromocytoma. Pheochromocytoma during pregnancy is also a challenging task where the pregnancy with hypertension is also mostly coincide or they create a confusion. But certain point where the paroxysm or the presence of hypotension or hypertension, which is not there in pregnancy, and presence of this presentation before 20 weeks of pregnancy is more favoring toward the pheochromocytoma. So very practical in pregnancy, early diagnosis is better. If required, do surgery in the second trimester. If diagnosed late, wait for the delivery, better to go for the cesarean section and post-delivery, we have to reach out for the pheochromocytoma. Diagnostic mortality, biochemically, it is same as non-pregnancy, but to localize it is better to use ultrasound and MRI without contrast, and it should be differentiated from the pregnancy-induced hypertension.
So thank you again, Dr. Ritesh. So there are some questions from the audience also. So Dr. Anulekha John has asked that how much should you rely on imaging characteristics of pheochromocytoma in order to distinguish them from other adrenal lesions? And have you come across a pheo that is hypodense? So anybody among the panelists who would like to take that?
Very rarely we are come across with the pheochromocytoma in the CT scan showing the hypodense lesion, because the hypodense lesions are more confusing to the adrenal adenoma or the benign adrenal tumor, where the lipid content is much more there. And I have said that if the HU field is less than 10, we are mostly not suspecting pheochromocytoma. But certain in older articles, certain things are there where there is a finding of pheochromocytoma with hypodense lesion, but I have not come across during my clinical practice or in my tenure in the endocrine department.
Dr. Shruti?
I agree with Dr. Ritesh. I have never seen it hypodense as well. I agree to that point. And I think we totally rely on the, I mean, of course, there is a biochemical aspect as well, but the radiologist discussing, as I told you earlier as well, discussing with them makes a huge difference. You know, you can pick these lesions by their appearance in the CT or MR with the necrosis. They have this characteristic cystic changes with necrosis inside. You cannot, I mean, if you have a good MR, the T2 weighted image or the CT scan, where you can actually easily pick up these images just looking at the imaging characteristics. That's where we really need to put our clinical judgment and correlate the clinical features, imaging, and the biochemical modalities and decide on how to sort of take this patients forward.
Thank you, Dr. Shruti. So, Dr. Rakesh, I think we had a very excellent discussion. So, thanks to Dr. Ritesh for the excellent presentation, and to Dr. Shruti and Professor Ibrahim for their very interesting inputs, and we lot of our doubts got cleared. So, your final words, Professor Sai.
Yeah. So I would say that we had a very good discussion. We had a very excellent presentation by Dr. Ritesh, and then we had a good discussion with inputs from Dr. Shruti, Dr. Ibrahim, and actually we discussed all aspects of pheochromocytoma diagnosis, management, and I think this was a very interactive and useful discussion that we have, and I'm sure all those who attended would have benefited from this presentation and the discussion that followed. So I would like to thank all our participants today, all our faculty, Dr. Ibrahim, who has joined us he's right now in the UK, so he's joined us from there, Dr. Shruti, and who has spared time to join us today, Dr. Ritesh, who did an excellent presentation, and also to Dr. Saptarishi for taking putting in all the efforts to get all the faculty together for this program, and I would like to thank all of them for their contribution, and I'm sure all those who attended would have benefited from the discussion. Thank you. Over to the Samarth Pharma. I would like to thank them also for organizing these webinars on endocrine and on adrenal medicine, and we have called this the EPIC series. Thank you once again for this.
Right, sir. Sir, on behalf of Samarth Life Sciences, I would also like to extend a heartfelt thanks to all the esteemed panelists and delegates who have taken time from the busy schedule and attended today's webinar on pheochromocytoma. Also would like to express our sincere gratitude towards all our national conveners, Dr. Sahai, Dr. Ganpati, and Dr. Kalra, for helping and guiding us to organize this webinar on usually less discussed adrenal disorders and adrenal medicine. A big thank you to all of you from Samarth Life Sciences family. Proud to be the only manufacturers in India of hydrocortisone tablets, that is Hyzone, and fludrocortisone, that is Floricort. Thank you very much. Stay safe, stay healthy. Yes, that's all.
Thank you.
Thank you.
Thank you very much. Good night.